positions for an ultrasound guided injection or ultrasound guided procedure for the lumbar spine. So the common positions are sitting, prone, and lateral decubitus. But in most of the cases, we prefer doing a prone or lateral decubitus position, unlike the spinal anesthesia where the sitting is usually preferred by most of the anesthesiologists. But here we prefer under ultrasound guidance either prone or lateral decubitus position. While the patient is prone, we usually put a pillow below the abdomen. So giving the advantage, the posterior elements get stretched so we can see the structures more clearly. And for certain areas, like I have already told, that whenever we are thinking of doing a lumbar sympathetic block from the, then we can go for the lateral decubitus injection. We have to go for the QL block, then also we can go for the lateral decubitus position. So depending on your convenience, okay, you can actually ask the patient to rotate. But remember, in lean and thin patients, it is easy to do the procedures in the lateral decubitus position. But when it comes to the old patients, it is, or sorry, when it comes to the obese patient, it is usually preferred to do in a prone position. Now coming to the positions for the probe. Usually in lumbar spine, we have certain fixed positions by which we evaluate the lumbar spine. So from the center, it is the median sagittal view, where we are actually exactly at the center over the spine. This view is good for certain procedures. For example, if you have to go for the intraspinous ligament injection, we can go for this view. Then we go to the paramedian sagittal view. Now, in the paramedian sagittal view also, we have certain specific areas of seeing the structures. The first one after the median sagittal view is actually the laminar view. So definitely, initially we'll be at the midline, so we'll be over the spine. As we move slightly lateral, we'll be moving over the lamina. And when we are moving over the lamina of the spine, then what will happen of the vertebra? Then what will happen? We'll be able to see a little bit of the anterior complex. Whereas it is possible to see in the midline as well, but I have already told because of the angulations, we see a little less, we don't see much. But as we go slightly to the lateral or here to go to the paramedian view, then we see the structures better. And not only lateral, but as we move slightly paramedian oblique, that means we are looking a little from the sides. So basically, if this is the spine, okay, if this is the spine, then we'll be looking, we'll be putting the, think this is my probe, okay, this is my probe. And when we are scanning from the midline, then it will be like this. And when we are looking like this, making it slightly oblique from this side, so what will happen? We'll be able to see the anterior complex better. And when we want to do a assisted spinal or assisted, there might be a patient where you are not able to find out a space and you are not able to put the spinal anesthesia, then also we can go for the assisted area injection, and through this area, through this window, basically in between the lamina. So this is a good way, that is known as the paramedian sagittal oblique view. Okay, now next view comes over the articular pillar. So basically when we are over the articular pillar, we can see the mammillary accessory body both together. So if you look here, a little bit difficult here actually. Okay, let me do one thing, let me switch off so that we can show you my, okay, spotlight for everyone. Now in this picture, no, it is not seen beautifully. Okay, in this picture, now it is seen better. Okay, in this picture, if we come to this area, see, I'm holding a very small card like thing. Okay, just take it, this is a Google Pay thing. So if you just focus, let's see. So if we are holding it like this, okay, holding the card like this, so basically we are going through this plane. Difficult. Okay. Not getting focused properly. No, not possible. Okay, leave it. So basically, in a plane, we are getting, I'm just telling you because it's not being seen in this camera beautifully. So let me, I just listen that when we are coming to a plane like this area, okay, just over the accessory process and mammillary process. So basically this accessory process and mammillary process, they will be one after another seen in the same plane. And when both the structures are seen in the same plane, this is actually known as the camel hump view, because in the camel hump there is a large hump and a small hump. Here also we'll be able to see a large hump and a small hump, and that is known as the camel hump view. So that is the articular view or the camel hump view that we'll be able to see if we go further from the laminar view. Remember, laminar view looks like a head of a horse, so it's known as the horse head view. Whereas the articular pillar view or the articular process view, where actually it is over the mammillary and accessory process, it looks like a camel hump. So it is known as a camel hump view. So let's go back to the presentation. Okay. So here you can see when we'll be going at this point, we'll be seeing the camel hump view. And then if you go further, then there will be only the projecting transverse processes. So it will be the transverse process view, or we also call it a finger-like projections or a trident view. Why trident view? That I will come, because the shadows look like a trident. Okay. So these are the views previously in the slide. Whatever we have described these views, these are basically the all longitudinal views or long axis views of the lumbar spine. Now there are two views which is important for the short axis view. One is known as the spinous process view and one is known as the intraspinous view. Regarding these two, I have just discussed a little at the beginning with the spine. So here we'll be seeing the spines clearly, and here we'll be able to see the open facet, we'll be able to do the median branch block. So these two views are very, very important. Next, move to the identification of the structures. So the planes we have already described. Basically, in long axis, we commonly see these planes. That means one over the spinous process, one over the lamina, two views, one directly over, one oblique, that means pyramidal sagittal oblique and pyramidal sagittal. Then over the facet joint, then basically over the facet joint and over the mammillary process are a little same, because at the initial part of the facet joint we do not have the mammillary process. Then we come to the mammillary process, and then once we are over the mammillary accessory process, then we can see the camel hump better, and then we have to go to the transverse process. Whereas in short axis view, one we see over the spine, that is the spinous view, one is the intraspinous spine or the intraspinous view, and one is the oblique view. Oblique view I have not discussed, I will come to later when I will show you, because in the oblique view we can see that club or the shamrock sign much better. Now let us show you a little bit of the longitudinal scans. So here you can see these are the two scans. So here let us start from the most lateral side, that is the transverse process view. So transverse process view is the lateral most part. So here we will be able to see the transverse processes, and then we will be seeing the rotatus, this intertransverse lateralis muscle along with the ligament, intertransverse ligament. Okay, so this area will remain here. Okay, so that is the transverse process view. Here in the transverse process view, above you can see the erector spinae muscle. Here at this point we can see the transverse processes. Here we are having the intertransverse ligaments, okay, or you can call this the intertransverse ligament complex as well. Below we have the psoas major muscle, okay, and then below the psoas major we are having the peritoneum, and we will see it is moving with the respiration. And when in the oblique view, in a normal size probe, usually it shows three transverse processes together in most cases. So it is known as the trident view because it looks like a trident. Okay, so that is why the name of the transverse process view is a trident view. Here it is looking like the same top of a trident. That is why it is known as a trident view. And in this intertransverse complex, we have a muscular portion that is basically the lateralis muscle, and then we have a, apart from the muscular portion, we have a ligamentous portion, which is hyperechoic. Now, next, coming to the pyramidal sagittal view at the articular level. So here we will be seeing So basically from the lateral side, we are moving slightly medial. So at this point, we will be seeing this camel hump view. So what is the camel hump? This is basically the topmost portion. So this is the hump that is basically the mammillary process, and here is the smaller hump. Here is the smaller hump. These are the accessory process. Okay. So as I told, it will go over the mammillary and accessory process, and in this area, we will be seeing the foramen as well, because it is at the level where the foramen is. So here at this point, we may able to see some vessels, that is the radicular vessels of segmental radicular arteries, they are moving at this point. Okay. So that we might be able to see. Here you can see some areas, and also the nerve roots, they are coming out to this area. So that we might able to see. And this muscle is the erector spinae muscle. Okay. Next move, slightly more medial. So this is the camel hump view. Next, slightly more medial, already told. Next, we'll come to the laminar view. Okay. So in the laminar view, also known as the horsehead view, here we can see the laminas, and then we can see the gaps. So basically, these are the posterior complex. This is the anterior complex, and in between we have the cerebrospinal fluid or the thecal space where we have the nerves. And the laminas look like these areas. This is known as the horsehead. And if you make it oblique, then you will be seeing these structures better. And that is why in most cases, instead of while doing procedure, instead of going to a pyramidal sagittal view, we usually go for the pyramidal sagittal oblique view. So we'll be coming slightly from the side, but if you're coming in plane, it doesn't cause us any problem. Rather, it makes it a little easy to follow the structure. So this is the horsehead view. In the horsehead view, we see here the posterior dura. Here we can see the anterior dura, main part of the anterior complex, and in between we see the lamina. Okay. So what are the structures? They are from posterior to anterior. Basically, middle we have the thecal space. Anteriorly we have the anterior dura. Then we have the posterior longitudinal ligament. Then we have the posterior part of the vertebral body. Similarly, posterior to the interthecal space, we have the posterior dura, fat-filled posterior epidural space, and ligamentum flavum. Hope you have understood this part. I have talked, I think, twice or thrice. It is not a problem. Now coming to the important point, because in fluoroscopy, counting the vertebral levels are very, very easy. It's not difficult. But when it comes to the lumbar area, counting under fluoroscopy, under ultrasound, it becomes a little bit difficult. Why it becomes a little bit difficult? Because in lumbar spine, the problem is that we sometimes can miss this echoes. So to count the vertebral level, there are two tricks that works best. Number one, go to the pyramidal sagittal oblique view. That is the best view, there is no doubt, where we can see the anterior thecal space best. And you have to go one by one, counting from the below, and then you can see at which level you are. Okay, so that is the busiest way. Some says it is through the spinous process view, but remaining at the center every time over the spinous process becomes difficult. Sometimes you might go slightly left and the spinous process view is lost. So it can cause problems. So usually we prefer remaining in the hot side view to count the levels. Okay, and in that way, from the S1 we can move up. And remember, someone can ask that if there is an extra vertebra, is it clearly visible? No, in lumbar spine, lumbar ultrasound, it is possible. It is not impossible. If you are very attentive and give a lot of time, you can actually count those areas. But we usually take the help of MRI or CR X-ray before. That's much easier way. Usually, most of the patient while evaluating before the ultrasound, usually we got these things. So in that way, we can check if there's extra vertebrae above or below, whatever it's there that we have to know before. So these are the things we have to know. Then the spinous process view is a central view. I have told you, keeping everything in the spinous process view sometimes becomes a little bit difficult. The cause because you might go a drift from the midline. So I will show in the spinous process view, it looks like this. These are the spinous processes. Basically, these are the spinous processes of the lumbar vertebra. These are the intraspinous spaces. So here we have the supraspinatus ligament. Here we have the intraspinous ligament. Then here this black area is basically the CSF or the thecal space. Posterior to the CSF, we have the ligamentum flavum. and this portion is basically the posterior complex, and here we are getting the shine from the posterior part of the vertebral body, which is a bone. Along with just behind the bone there is the posterior longitudinal ligament, so we are getting that shine from here. Similarly, here we can see another anterior complex. Okay, so this is known as the midline view in case of lumbar spine. Now, this is most important because most of the procedures will be doing in this view. Now, can anyone tell it is the which view is this? This is the spinous view or intraspinous view? Transverse view is okay.
This is spinous view.
Why?
This is spinous process, no? Longest the superficial.
So this is one of the mistakes. That's why I have asked. Remember, here we can see a hyperechoic shadow. Here we can see a hyperechoic shadow. But at this point, we cannot see a hyperechoic shadow like this. Just compare with these areas. Okay, can we see there? The answer is no, we cannot see. Rather, we can see a shadow here. Here, remember, supraspinatus, intraspinatus ligament, they are also a little hyperechoic. That is why you are getting this view. But this is not a hyperechogenicity of a bone. This is the hyperechogenicity of a bone. So here you can understand these are actually the bones. These are not the bones. Okay. So this is the supraspinatus and the intraspinous ligament actually. And here we can see the thecal space. Here we can see the anterior complex. So keep your eye on the anterior complex. So if you can see the anterior complex, then definitely you are not over the spinous process. Clear? Rather, in the intraspinous view, we see this cleft in a very good way. Which is this cleft? This cleft is actually facet. Okay, so we can see open facet, and it's a good area to do an intra-articular facet injection. I'll show you the other view as well, both here and on the patient. So first come to the spinous process view. So this is the spinous process view. So I think you can distinctly differentiate from the spinous process view and intraspinous view by looking at this area. Here we do not have anything. Okay, so that is the thing. Sometimes it is a little bit difficult to understand by looking the shine here, but definitely it is easy to understand by looking at this point. There is no echoes coming from below. Okay, and this is the second step. This is the third step. Okay, so basically it is over the transverse process. Similarly, like I have told, at this area, it is sometimes a little bit difficult because the hyperechogenicity that is came not from bone but from the interspinous ligament, supraspinous ligament. Here can also intertransverse ligament can show a little hyperechoic. But if when we move up and down, that means where you are over the bone and over the intertransverse ligament, similarly over the supraspinous ligament and over the spine, then also you can make the difference. When it is becoming more hyperechoic, it is the bone. When it is less hyperechoic, it is basically the ligaments. Sometimes a little bit difficult, but with practice, it is easy. And the most distinctive feature is this one. Here, there is no anterior complex. That means it is the spinous process view. Now, when move to the intraspinous view, that means in between two transverse processes, it will look like this. So here we can see, here this area is the anterior complex. Okay, and here there is the bony structure is not visible. Here sometimes if you are not in a same plane of the facet, you might not be able to see because the spine is having the curvature. Though we try to reduce the curvature by putting pillow, but sometimes it happens. But though it is an intraspinous view, but the facet is not exactly falling over it, so you can see a little bit of the facet, but the cleft is not that clean compared to the previous picture that I have shown. Okay, so this is basically the intraspinous view, and here this view is basically from the either transverse process or the interspinous ligament. When we are doing on a patient or volunteer, it is very easy because you can compare moving up and down, but just seeing one view, it is a little bit difficult to differentiate whether we are over the spine and over this thing. Okay, now both median branch block and the periarticular injection or the intraarticular injection can be done with the ultrasound. But remember, ultrasound only can show this picture. So basically, under ultrasound, we have to see this structure, we have to see this structure and this structure like that. This, and this. So in that way, we have to differentiate and know all the structures here. Okay. Now, these are very, very basic things, not going to it. The indication of the lumbar facet joint injection. Hope you know the basics of the facet. So basically, it's a back pain. Then it is mostly related to the extension and rotation. And there is facet arthritis. It could be because of the spondyloarthropathy, or it sometimes can be because of the traumatic, or it can be associated with the other causes that like old age degeneration that is causing, or sometimes it could be possible because of the previous surgery of the disc, or sometimes disc degeneration. Disc height is reduced, facet is overloaded, and then facet has become painful. So basically, it causes localized lumbar pain. And for the facet joint injections, we have to look at this picture and then we have to inject. So we can do the facet joint intraarticular injection and facet joint injection. This is the compilation of the studies. There are multiple studies. Some studies have shown that the ultrasound guided facet injection can have a high accuracy around 95%. Some studies shows around 85%. Some studies shows around 91%. So there are different studies, and based on which, see, these are not very, very big studies, but you can see it is comparing the ultrasound either with the fluoroscopy and CT scan, and they have found that the respective success rate when doing the ultrasound guided with other conditions. But remember, over 80% is not a very bad success rate actually. So it is a comparatively good success rate. So it's not a very bad success rate. So it can be done in certain conditions, definitely. So these are few more studies and their conclusions. So the lowest we got around 62% in this study, and in the other studies, as definitely it was older studies, but they have shown the successful needle placement is possible with the help of the ultrasound. So facet intervention, usually for the medial branch block, we have to go in between these two steps. So basically for the median branch, as I told, this is the first step, this is the next step, this is the third step. So in between the second step and third step, you have to put the needle, and I prefer moving slightly up after touching so that we can actually get the stimulation of the median branch. And while injecting, it is much better if you have a nerve stimulation or you are doing using an ultrasound or radio frequency needles, so that you can have both the sensory and motor stimulation, and you can match that whether this is matching with this. When you are doing only with a needle, and sometimes it is very difficult because in one area, that is the neurostimulation, you don't have. So basically, if you have a nerve stimulator along with the ultrasound, that gives a better result. Obviously, if you are getting the stimulation of the median branch at a very low voltage, that gives a very good idea that you are close to the medial branch. So this is the transverse inline positioning of the needle. That is the usual positioning that is done for the medial branch blocks. And we can go for the facet joint intraarticular medial branch and the intraarticular injection as well. So here it is the intraarticular injection. Here, see in this picture, this is the facet joint medial branch block. You can see the needle going to the junction of the in between the transverse process and the facet joint. So here at this corner, and here we are seeing the open cleft that you have to see carefully by evaluating moving up and down, and mostly it is found in the interspinous view, but it can change depending on the plane at which it is falling because of the curvature of the spine. So here, once you get this cleft, you have to try to put the needle inside the cleft under the ultrasound guidance, and then you have to inject either intraarticular, most preferable, or periarticular injection. So these are the things. Nerve root block, as I told, nerve root block having a big disadvantage that here we do not have the contrast, but still we can perform the nerve root block, especially in cases we are not able to reach there in some cases, and then we can do an assisted injection. And in the nerve root block, usually the needle is passed at this area, but I will show you a technique that shows a little better. Okay. And last but not the least, this is the technique basically, nerve root block in the sagittal view. That is comparatively easier. So I will show how to do that. Basically, in this picture, but once you have to tilt the probe slightly, the upper part of the probe slightly laterally, so that in the lower part of the probe you can see the camel hump, and in the upper part of the probe you can see basically the finger-like projection view or the transverse process view, and in this area we will be seeing the radicular arteries moving. So by this picture also, by coming from this area, you can inject in the inline view, and here you are actually seeing the artery. The chances of going into the artery is slightly less compared to the other area, but definitely it is not a proven study. That means the number of studies to prove those things are not there. So next, but not the least, is the lumbar sympathetic block. Remember, this block is possible, especially if the patient is very lean and thin. In thick patients, it is a little bit difficult. But in this picture, you have to see the structures clearly. Okay, so here you can see the aorta in the anterior side. Here we are having the spine in this side. And here we have the transverse process. So here in this picture, at one structure we can see beautifully is the shamrock sign. So here, this part of the clove is basically the which muscle? Can anyone tell?
Quadratus lumborum.
Yes. This portion muscle is the psoas. Major along with minor will also be there. And this portion of muscle is basically the erector spinae. And this is the transverse process. So that is the stem of this club sign. Okay. So this is known as the shamrock sign. And the same picture, we can go, especially if we go at the three distinct areas, that means L2, L3, and L4, and then we put the needle like this. Remember, it is only possible in very lean and thin patients like this. If you can go and go to the anterolateral corner, you can actually go for a block in the area that is the lumbar sympathetic block. Okay, but you have to do at a specific level, L2, 3, and 4. Okay, now this is possible to do in very lean and thin patients, and in some patients you can do in an out of plane approach also. It is also shown in some studies that here in out of plane approach the needle is passed in between seeing the vertebral body and the intervertebral disc. Here the needle is put here, but remember, it is not easy, it is difficult, it is not easy. Okay, because only lean and thin patient you will be able to see. Now, last but not the least is the erector spinae block. There are multiple uses of the erector spinae block for us, the chronic pain physicians. Basically, it is the myofascial pain and sometimes the neuropathic pain. Remember, in this erector spinae block is actually invented initially for the neuropathic pain, and erector spinae block is not very old, it is new, just around 10 years back the block is invented. So it was initially invented for the neuropathic pain in chronic pain management, then it is used for the myofascial pain syndrome, and sometimes can be used for the cancer related pain also. And in acute pain management, it can be done in the thoracic area and lumbar area both. So it can be used in the rib fracture. It can be used for the post-operative analgesia for the thoracic, abdominal, and the spine surgeries as well. Other indications are the possible CRPS, failed back surgery syndrome, palliative care for the intractable pain. But for this indication, we do not use it very commonly. Okay. Now coming to the indications of the quadratus lumborum block. Here it is mainly for the post-operative analgesia for the abdominal surgeries, hip and pelvic surgery, pain management, chronic low back pain only if the myofascial pain involving those muscles, then acute and chronic pain in the lower thoracic and lumbar regions, and then trauma-related abdominal or frank pain, cancer-related abdominal or pelvic pain, post-cesarean section or gynecological surgery pain management. So it's a part of the acute pain management more rather than the chronic pain management. Now, as long as I am preparing for the ultrasound machine and the demonstration, Dr. Roy will be talking about the three types of QL blocks, that is the QL 1, 2, 3. So over to Dr. Roy, and let me prepare for you the volunteer, and then I will show the structures. Chinmada, are you there? Yes. Okay, so I'm becoming a silent. Any questions, by the way, before going to that part? No questions.
Okay. So, as Dr. Devjyoti told, that QL block is not actually for chronic pain management. In our chronic pain treatment, hardly we ever go for this QL block. So it is mostly done for acute pain management and postoperative analgesia. So the patient is must be lying in this way, in this position, say lateral decubitus position. So we can go from this side also towards the back side also. We can insert the needle, or you can insert from the abdominal side also. Both are possible. And where it will reach, so it will reach actually. So here it is the same thing. Our when ultrasound probe will be placed, the curvilinear ultrasound probe will be placed in the flank area just above the iliac crest, just above the iliac crest. In that case, we will again see this one, these three muscles. Posteriorly will be the erector spinae, anteriorly psoas major, and just by the side of the transverse process, we will see the quadratus lumborum. So QL 1, 2, 3, even there is 4 also. So ultimately, it is just the needle position, needle tip position with respect to QL. That's why QL 1, 2, 3, 4. 1 means it is the anterolateral surface of the anterolateral margin of the quadratus lumborum. 2 means when it is in the posterior surface of the quadratus lumborum. Here, second needle, 2. And then comes 3 needle quadratus lumborum. 3 is actually anterior to the quadratus lumborum muscle. Every time we are entering, either patient is mainly patient is lateral decubitus position. So here you can see it is near to the midline, our needle entry. But in QL, when it is QL 1, so mostly it is from the abdominal side. From the abdominal side we enter, and here it is from the posterior side. So QL 1, 2, 3. Just remember, anterolateral side, posterior side, anterior side of the QL. And in some books I have seen QL 4. That means inject inside the QL, intramuscular injection of the in the quadratus lumborum. So what we actually want to achieve with that? So we want to block the cutaneous nerves. Okay, lateral cutaneous nerves and anterior cutaneous nerve of the abdominal wall. And mostly it is done for the lower abdominal wall surgery, or say hip surgery, even up to hip surgery. So in those areas, to just this is for the abdominal wall surgery, though it is written that of course for visceral sensation also it gets blocked, but mainly it is for somatosensory sensation. So here you can see this is a picture of thoracolumbar fossa. Okay, so see, this is the posterior side. Thoracolumbar fossa has anterior layer, middle layer, posterior layer. Quadratus lumborum is between the anterior and middle layer. So when we are injecting, we know that where we are injecting. So our mainly always we go for the QL3 block. That is the transmuscular block, trans-QL block. Our needle comes from the posterior side and enters here, just between the anterior layer, below the anterior layer and above the QL. Okay, so in this way we'll go for that. And mostly, so QL1 block is done when the below the umbilicus local anesthetic action is wanted. We want to just for analgesia below the umbilicus surgery for anything. And if it is QL2 or trans QL block, means QL3, when I'm putting the needle anterior to the I'm going through and through the muscle, and I'm putting the needle anterior to the QL. That is either above or below the umbilicus, doesn't matter. So whole area should be a broad area on the abdominal wall, mainly in the flank side. So you understand that lateral cutaneous and anterior cutaneous nerves are blocked. Lateral cutaneous or anterior cutaneous nerves of this cutaneous nerves of ilioinguinal, iliohypogastric, these nerves or subcostal nerves. So these nerves, all cutaneous nerves are blocked. Okay, so you can go for this block in a acute pain scenario. Okay. So here you can see the picture when the patient is in a lateral decubitus position, and we are seeing from the flank. So we know, so as soon as I see this rounded structure, then I know this is anterior side. That means this is psoas major. This side erector spinae and this side quadratus lumborum. So needle is coming from this posterior side and needle is entering and it is going just anterior to the QL. This transverse process is mostly L4. Mostly it is a L4 transverse process. Straight I am seeing the L4 transverse process. Okay. So this is the same thing. This is actually QL1 block, which is not much important. QL3 is much better. So here also, after giving the drug, injecting the drug, local anesthetic is being spread between QL and psoas muscle, QS and psoas muscle. So this local anesthetic is being spread. Okay, this much only.